the diagnosis and the management. So the odontogenic infections are usually multibacterial um, type of infections that's in everyone's mouth. So we have about more than 700 species of bacteria identified as normal flora in the oral cavity alone. So since we start um, to grow as infants, we have more aerobic bacteria as we start, but as the teeth are erupting, we start to have anaerobic bacteria and fungus plus viruses, as they can be harbored by the teeth formation. And so some of the common oral bacteria that we have are aerobic and anaerobic. These are some of the commons, mostly streptococcus are the aerobic most common bacteria types, plus the lactobacillus. As for the anaerobic that we can have, actinomyces species plus the bacteroides species and others. So the odontogenic infections are caused by many species, as I said, and they begin as aerobic bacteria and therefore ends up having anaerobic colonization as the infection progresses. Many of these new species are anaerobic, and antibiotics therapy, when indicated, must include the ability to fight these new bacteria, meaning the anaerobic bacteria when it progresses on advanced levels. As for the anatomy, we need to have a clear understanding of this because of it is essential in treating this type of infections. With larger infections, this anatomy is often distorted, so it's really hard to really know exactly where things are as they are distorted as they become big, or maybe they are completely torn away apart. Odontogenic infections spread along the facial planes, so these are like tissues which looks like fascias, which are fascias actually, and they give departments, I would say, of different compartments in the face and the surrounding of the neck. So here is the small sketch of how it would look like. So we have teeth, we have the vestibule and the spaces that are around. So we might have like the palate on the top, and we might have the palatal space on the top here, the sinus in the maxilla, and on the buccal beneath beneath the cheeks and the buccinata fats, and underneath we have the buccinata muscle, and we have also the vestibule where usually most of the odontogenic infection starts from or just confine themselves from. And we also have the sublingual space and many more others that are not here. So the origins of this, so the facial space infections are caused by the patient's normal oral bacteria, as I've said. This infection can mostly come from this type of diseases, caries teeth, periodontal disease, and rarely traumatic oral wound can cause spreading of infection of the facial space, as well as the post-surgical oral wounds. It is also uncommon to see that. So while we examine the patients, what do we usually do? It's very crucial to understand the chief complaints and to take the history of the present illness to know how actually to make the treatment plan for a particular case. So for this, we also need to take vital signs, including the temperature, and we need to also to inspect, palpate the area, not always necessarily the maximum incision opening, because we don't usually need to do this unless we are going with the treatment, and intraoral examination is really required, and the radiographic examination as well. So the patient will initially complain of pain. So please ask, how long has this been hurting you? How did your swelling start? Have you noticed any pause? Any difficulty swallowing or breathing? So these are some of the questions that usually you can ask a patient so that it can give you a lead to what type of infection and where it is spreading or for how long is it spreading. And as for the normally that we know the infection and the inflammation usually follows, we have these signs that usually we see. We have the redness, the swelling, the pain, and the cold temperatures. And the fifth one is the loss of function, which is not mentioned here. And those are the five critical signs of inflammation. So as the infection begins, it starts as cellulitis, which diffuse as an inflammation of infectious origin as well. It generally takes 2 days to go from cellulitis to abscess. And usually this also leads to trismus, which is usually when the masticatory muscles are involved. So the patients are unable to open their mouth. So what are the differences of cellulitis and between cellulitis and abscess? So cellulitis is usually early, diffuse erythema. It is usually painful and very hard and very hot on touch. So if you see this most of the time, it will be still the early infection, which will be in cellulitis form. And later on, it becomes the abscess and it is localized and possibly it is less painful, but sometimes you can still have a lot of pain and it is usually softer and fluctuant in the swelling. It's not very hard. So cellulitis in the head and neck incision and drainage is generally not indicated. It is treated with the removal of the source of infection and the antibiotic therapy usually alone. As for the abscess, they are treated with the removal of the offending tooth with the incision and drainage. We place a drainage tube, which is usually recommended, and we also advise for the cultural and sensitivity of purulent discharge when recommended. As for the usually different locations where the odontogenic infections goes to, the first one is the vestibular and subperiosteal space, most common, very most common, and buccal space, the canine space, as well as the submandibular space. We might also have the submento, sublingual, and the masticator, the lateral pharyngeal, and posterior pharyngeal, which is usually the danger space. So, most common type of abscess, which is the vestibular subperiosteal abscess. Sometimes we might also have the very most common that we see usually, and we don't even need to go for incision and drainage, which is the periapical abscess. Usually it is confines in within the bone still, and from there it can go to these spaces, vestibular and subperiosteal abscess space. So it is usually characterized by the intraoral vestibular swelling. This is how it spreads. So from the tooth infection, it spreads to the periapical region and it can go to the vestibule. This is one of the case that you can see. They insert the needle and they can aspirate pus coming from the vestibule. So we aspirate the abscess. Treatment involves removal of the offending tooth, incision and drainage, and antibiotics may not be usually necessary because it is confined into that area. This is how it goes. Incision, and drainage, and this is the tube for drainage. As for the buccal space, so commonly arises from maxillary or mandibular posterior teeth, characterized by swelling of the cheek. Inferior border of the mandible is usually palpable. So this is the main, I would say, main indicator of differentiating where the spaces might be. If you can easily palpate the mandibular border, then that means this space is in the buccal space. If you cannot, then it means it is in the submandibular space. This is how it looks like case. So you can see there is a swollen cheek. So the treatment involves removing the offending tooth, intraoral incision and drainage, and oral antibiotics are recommended for this type of case. So canine space commonly arises from maxillary canine and premolar teeth, characterized by flattening of the nasolabial fold and preceptor-orbital cellulitis. So with this, you can see the difference of the nasolabial fold. Here is still present, but here it is becoming more flat. So this is the canine space abscess, which might be coming from a canine or a premolar. The treatment involves removing offending tooth, intraoral incision drainage. We might not need to consult for ophthalmologists, and oral antibiotics are usually recommended. So the submandibular space abscess, commonly caused by mandibular posterior teeth, characterized by firm, painful swelling of lower face. The inferior border of the mandible is not palpable, and for sure this is an urgent situation as it may lead to more complications, which are the airway obstructions and maybe even the spread of the infection to the mediastinum, which might also lead to sepsis and might be fatal for the patient. So that's why this one is very urgent, and it's also dangerous for the patient. So this is how it looks like. Starts from the mandibular tooth, molar tooth, and it can spread to the submandibular space. So with this type of infection, you will not be able to palpate the border of the mandible most of the times. This is how it looks like. So you can see there is a small amount of cheek swelling, and as well as underneath the skin of the mandible, and it keeps going with the covering the border of the mandible as well. On the CT scan, this is how it looks like. A swollen here, but here you can see the abscesses. So the pre-skin of the then aspirate the abscess prior to incision and drainage. And sorry for that. So the treatment involves removal of the offending tooth with external incision and drainage of the area. This is the other one which you can use external incision and drainage for the area. And intravenous antibiotics are recommended, as well as hospitalization of the patient. Submento sublingual space, commonly caused by mandibular anterior tooth and from the spread of the mandibular space infection. The submental space form midline swelling of the anterior upper neck. As sublingual space, the tongue is elevated. Remember the mylohyoid muscle. By this, it shows that the mylohyoid might be underneath the infection most of the time. So this is how it looks like. and the tongue is elevated, as you can see onto this patient. So this is the mylohyoid muscle, which actually is underneath the abscess, which comes from the anterior mandibular teeth. So this is another example of a patient with the sublingual submento space infection. So how do we treat this? We aspirate the abscess. Treatment involves the removal of the offending tooth with external incision and drainage. Intravenous antibiotics and hospitalization are recommended. As for the masticator space infection, it occurs as spread from the buccal space or submandibular space infection. These usually cause trismus, and trismus occurs from the inflammation of the muscles of the mastication. As I said in the start, medial and lateral pterygoid plus the masseter and temporalis muscles are involved. This can quickly spread to the lateral pharyngeal space, which is literally an urgent case. So this is how it looks like. These are the masticatory muscles, and it can easily fall down into the lateral pharyngeal space. So to diagnose this is it is usually clinical, but sometimes CT scan is required. Difficulty to distinguish between cellulitis and abscess is usually something hard to notice because all of them may cause trismus and you cannot actually feel very well as to the previous space infections. Treatment involves removing the offending tooth as well and draining other spaces affected, including masticatory space. Intravenous antibiotics and hospitalization is usually required. So generally arises from the spread of submandibular space infection or from an infected tonsil. This is the lateral pharyngeal space abscess. So it is usually characterized by trismus, deviation of the uvula due to the pharyngeal wall inflammation and possible airway compromisation. So the CT scan usually gives the diagnosis. It helps with the diagnosis, and this is an emergency, the lateral space infection. So this is how it looks like in the CT. So this is why we need to have it, because it is usually intraoral and sometimes it's not usually visible with the soft palates and the uvula alone. So you need to have a radiographic image to help you diagnose this type of abscess. So what we do, we aspirate, which is usually difficult. The treatment involves the removal of the infected tonsil or tooth with external incision and drainage of all spaces. Antibiotics, which are intravenous, are really required here. So retropharyngeal space, which is also one of the danger zone, it is rare. It is commonly called retropharyngeal space or the danger space. So it arises from the spread from the lateral pharyngeal space, the previous one, and can easily spread to the mediastinum. This is an emergency as well. So with this, you can see some of the signs of these abscesses in the retropharyngeal space. So how do we do this? To deal with this case, we need to aspirate the abscess. The treatment involves the drainage of all affected spaces, broad spectrum intravenous antibiotics, and intensive care is required. So we usually need to have a consultation with thoracic surgeons, as this usually spreads to the mediastinum. So this is another type of odontogenic infection, Ludwig angina, rapidly spreading cellulitis involving submandibular space bilaterally and sublingual space and submental space. It is uncommon but very dangerous. and it is usually an emergency. So as you can see, it involves like three spaces: the sublingual, submento, and submandibular spaces bilaterally, and it is also characterized by the lift of the tongue and a swollen mandible. You cannot bilaterally palpate the border of the mandible. So we remove the source of the infection for the treatment, wide exploration, incision, and drainage. So in the submento, sublingual, and submandibular spaces bilaterally, including drain placement. So that's how we deal with it. And intensive care with broad spectrum antibiotics. We have also necrotizing fasciitis, which is also not that common, but it can happen as well. So it is a rapidly spreading infection characterized by necrotic, liquefied subcutaneous tissue. It is mostly done by virulent bacteria species and the host with a compromised immune system. So this is an emergency, and this is how it looks like. And I've had recently a case like that, and I wanted also to show you some of the pictures. And this is one of the case that I have encountered in my practice, and it is very rare to find, but it is very disfiguring disease. Necrotizing fasciitis really do the big damage. As you can see, all of these spaces were involved as cellulitis before, and then became as necrotized as an abscess, and pusses were being discharged, and even the neck was as well affected. So debridement is something which is frequent and needs to be done and redone on daily basis, not daily basis, I would say on most occasions, until all the necrotic tissues are removed. And multi-speciality are usually involved: critical care, maxillofacial surgeons, and ear and nose surgeons, infectious diseases, and plastic surgeons usually are needed. So antibiotics in general are prescribed too often. So let's talk about antibiotics. Usually they give antibiotics too often. So when are antibiotics indicated and when not? Are they not indicated? So we have they are indicated when we have facial space infection, pre-surgical for invasive procedures, and pre-surgically and post-surgically for immunocompromised patients. It is not indicated when a patient has a toothache, intracanal endodontics, or tooth decay, or even having a drainage of a fistula. So if you have a draining fistula, you don't need to give antibiotics if you have to remove that tooth. So when indicated, use high dose and narrow spectrum for a short amount of time. For most early odontogenic infections, penicillin or amoxicillin is a drug of choice. So amoxicillin 500 milligrams, one tablet 3 times per day for 10 days, or penicillin 500 milligrams, one tablet 4 times per day. If allergic to penicillin, give erythromycin. So for severe infections, metronidazole should be added, 500 milligrams, one tablet 4 times per day for 10 days. So antibiotics are not substitute for patient care. So you need to give more care, and as well as the incision drainage if in place. Look if the draining system is still draining, or if it has stopped, or if you have to remove the draining tube. So in summary, the odontogenic infections are relatively common worldwide. So prompt and aggressive treatment consisting of tooth extraction, drainage of all affected spaces should prevent spread of infection. And supportive antibiotics may be necessary depending on extent of infections. So I think this is all. Thank you very much. If you feel like you have a question, Maybe you can ask, and I will be glad to answer it.